All right, team, gather round. Welcome to today's explainer. We are stepping straight onto the hospital wards right now for some high-stakes attending rounds. Our goal today? Unpacking the tricky diagnostic approach to syncope, or, fainting. We've got a real medical mystery to solve together, so grab your imaginary stethoscopes, get focused, and let's go meet our patient.
Okay, so this is exactly how it always starts. The patient tells you, I was climbing the stairs, and the next thing I knew, I was on the floor. Now, stop and think about that for a second. What's truly terrifying here is the sheer abruptness of those words. There's absolutely no mention of feeling dizzy, right? No mention of the room spinning or getting hot or getting sweaty, just action and then complete darkness. This establishes the very real, very sudden stakes of our clinical case today. Just imagine going about your normal daily life, walking up a flight of stairs, and then suddenly you lose all consciousness, hitting the ground with zero warning whatsoever. That is terrifying for the patient, and honestly, as the medical team taking care of him, it immediately puts us on high alert.
So, as a resident on rounds, you've got to deliver what we call the one-liner. This is your brisk, confident summary that gives me, the attending, all the core details in a single breath. Our one-liner for today goes like this. We have a 68-year-old man with hypertension and known aortic stenosis presenting after a sudden loss of consciousness during exertion with no warning and a rapid recovery. Now, in medicine, every single word in that sentence is a massive clue. He's an older male. He has known structural heart disease. That's the aortic stenosis, which is a narrowing of the heart's main valve. And crucially, he had an abrupt exertional collapse. He didn't just pass out while sitting on the couch watching TV. He passed out while his heart was actively being forced to work harder.
Before we get ahead of ourselves, the crucial first step is establishing what exactly just happened to this guy. Did he have a seizure? Did he just trip on a step? Or did he have true syncope? True syncope is defined very, very specifically. It's a sudden, transient loss of consciousness caused by global cerebral hypoperfusion, which is just a fancy way of saying the entire brain temporarily lost its blood supply, followed by a spontaneous recovery. That last part, spontaneous recovery, that is key. If the patient required CPR or an electric shock from a defibrillator to wake up, well, that's not syncope. That is sudden cardiac death. We use this rule-out heuristic in medicine all the time, basically reminding us that our absolute first goal is isolating what will kill the patient right now. Our patient woke up completely on his own, so yes, it's syncope. But let me tell you, the line between syncope and sudden cardiac death can sometimes be uncomfortably thin.
Let's look at the usual suspects. When we break down the major etiologic categories, the actual underlying causes of syncope, it reveals a pretty complex picture. A massive chunk, like 40% of cases, ends up being undetermined. Then 25% are reflex, or vasovagal. That's your classic fainting at the sight of blood scenario. About 10% are orthostatic, meaning it's related to standing up and gravity. And 5% are neurologic or other random causes. But I want to draw your attention right to that 20% slice, cardiac. This 20% is the most dangerous slice of the whole pie. It carries the absolute worst prognosis, and as a medical team, it is the one category we must absolutely never ever miss. Let's break some of these down and see exactly where our patient fits in. Let's start with building a picture of the most common known cause, reflex or vasovagal syncope, making up about 25% of our cases. The pathophysiology going on here is actually fascinating. It usually starts with a specific trigger. Pain, extreme fear, seeing blood, or sometimes even just coughing or swallowing. So, step 1, this trigger causes an increased sympathetic tone. Your adrenaline spikes, and your left ventricle squeezes super vigorously. Step 2, because the heart is squeezing so hard, and often while it's relatively empty of blood, these little stretch receptors, mechanoreceptors in the heart wall, fire off a false alarm to the brain. They're basically shouting, hey, blood pressure is way too high. Step 3, the brain panics. It sends a massive parasympathetic surge right down the vagus nerve to compensate. Step 4, this intense vagal surge causes a sudden, totally inappropriate drop in your heart rate, your blood pressure, or both. Your brain temporarily loses blood flow and boom, you faint. We call this the hyperactive basalt-jarisch reflex. Now, it's totally benign, but honestly, does that really sound anything like our 68-year-old climbing the stairs? Not really. Okay, so what about the orthostatic and neurologic causes? Orthostatic hypotension makes up about 10% of cases, and this one is really all about gravity and fluid volume. When you stand up, blood naturally pools down in your legs. If you are volume depleted, say from bleeding, severe dehydration, or taking diuretic medications, your body just can't compensate. Your blood pressure drops and you faint. Then you've got dysautonomia.
Think POTS in younger people or autonomic neuropathy in older patients dealing with Parkinson's or severe diabetes, where the nervous system essentially forgets to tell the blood vessels to constrict when they stand up. But let's compare those scenarios to our patient again. On the neurologic side, things like a cerebrovascular dissection, a literal tear in a neck artery, can cause fainting, but true neurologic syncope is actually quite rare. And once again, our guy wasn't just standing up from his recliner or managing advanced Parkinson's, he was actively exerting himself on a staircase. Which brings us directly to the prime suspect, cardiac syncope. This is a highly dangerous form of syncope, accounting for that critical 20% of cases we mentioned, and it demands our immediate attention. It generally falls into two main buckets, arrhythmias and mechanical obstructions. Arrhythmias mean the heart's electrical system goes completely haywire. It might be beating way too slowly, which prevents forward blood flow, or beating way too fast in a chaotic rhythm like ventricular tachycardia, where the heart just essentially quivers instead of actually pumping blood. The second bucket is mechanical outflow obstruction. This is when the plumbing is literally physically blocked. We're talking things like a massive blood clot in the lungs, a pulmonary embolism, or a severely narrowed heart valve. Remember our patient's one-liner from the beginning? He has a history of known aortic stenosis. That is a massive, urgent clue just hiding right in plain sight.
Now, before we rush to a final, confident diagnosis, we really have to respect this number, 40. Even after a full, comprehensive medical workup with all our modern tools, the cause of syncope remains totally undetermined in about 40% of all cases. That is incredibly frustrating, both for us as doctors and certainly for the patient. But it really emphasizes exactly why our clinical investigation, our deep history taking, and our physical exam needs to be incredibly targeted. We aren't just out here taking wild guesses. We are actively hunting for very specific red flags that tell us whether a patient belongs in that benign, undetermined category or if they're sitting in the deadly cardiac category.
You see, the history tells the story. In syncope, the patient's story is literally your single best diagnostic test. We correlate these rapid-fire clues directly to their underlying causes. Think about it. If a patient faints during a positional change, like getting out of bed in the morning, we strongly suspect orthostatic hypotension. If they pass out while shaving or turning their head tight against a stiff collar, we suspect carotid sinus hypersensitivity. If they report a prodrome, meaning they felt nauseous, got super sweaty, and their vision kind of tunneled or went blurry right before they went down, that heavily points to a benign vasovagal pain. But consider exertion, passing out mid-activity. And remember our patient's exact quote? No warning, just hitting the floor. Exertion without a prodrome points a giant flashing red arrow directly at a cardiac issue.
So what does our high-yield workup actually look like on the wards? What tests are genuinely cost-effective and useful for us to order? First step, we check orthostatic vitals, specifically looking for a drop of 20 millimeters of mercury or more in their systolic blood pressure when the patient stands up. We can also perform a carotid sinus massage to test for that hypersensitivity we talked about, but, and this is a big but, only after checking for bruits. Bruits are those whooshing sounds in the neck that indicate plaque buildup. We definitely do not want to massage a neck, dislodge a plaque, and accidentally cause a stroke. Then there is the absolute mandatory test for every single syncope patient, the 12-lead ECG. Why? Because it is cheap, it takes literally 2 minutes, and it catches those dangerous underlying rhythms or electrical blocks. Finally, for a patient exactly like ours, an echocardiogram is absolutely essential to look at the physical, mechanical structure of the heart and check the severity of that aortic stenosis. All right, bringing the narrative back to our guy, it's time to conclude our rounds and fire off the resident's action items, the assessment and plan. So, our assessment? This is a 68-year-old man presenting with exertional syncope, absolutely absent warning signs, and a history of known structural heart disease. We must treat this as high-risk mechanical cardiac syncope, specifically critical aortic stenosis, until proven otherwise. Here's what happened. His heart valve was so heavily narrowed that when he climbed those stairs and his body demanded more oxygenated blood, the heart simply couldn't push it through that tight, calcified valve. The brain lost blood, and he went down. So what's our plan? We admit him immediately with continuous telemetry monitoring. We get that 12-lead ECG and an urgent echo to quantify exactly how tight that valve really is. We are placing an urgent referral to the cardiology and valve team because, frankly, he likely needs a brand new aortic valve. And crucially, we must counsel him on state driving laws right now because until this plumbing issue is fixed, it is definitely not safe for him to be behind the wheel of a car. Which brings us to the final, really sobering reality of this case. The clinical statistics tell us that if cardiac syncope is missed, if a patient exactly like ours is just sent home from the ER with a pat on the back, some fluids, and told they just fainted, they face a staggering 20 to 40% risk of sudden cardiac death within just 1 year. That is a truly fatal prognosis for a misdiagnosis. So as we wrap up our teaching rounds today, I want to leave you with this thought. By paying close attention to that exertional trigger, the complete lack of a warning prodrome, and his structural heart history, did we catch this mechanical obstruction just in time to save his life? Yeah, I think we did. Thanks for joining me on Rounds for this explainer, and I'll catch you all in the next one.